Hi everyone. Sorry, just adding the pinned comment. Okay. How do I pin this? And that's done. Hello everyone that's joining in. Hi. I'm just waiting for Dr. Underneath to join in so we can start talking about our topic. And I think he's here. No, he's not. Okay. There we go. West. How's everyone doing? Today we're talking all about vaginismus, which is a topic that a lot of you have questions around. Hi Doc, you're here. You just have to accept the request that I've sent you. So guys, today we're talking about vaginismus, nothing else. No other questions, no other queries will be entertained. If you have questions around vaginismus, please send them in and we'll have a chat about them. Dr. Sabharwal is a therapist, so he has a good idea. He also deals with sexual health issues, so he has a good idea on how one can treat this, because every time you guys ask me about vaginismus, I tell you the exact same thing, which is you might need to speak to a therapist and use dilators. So, has the doctor gotten my request? Is a question. Anyway, so yeah, I tend to give you guys the exact same response most of the time, which is that you need to speak to a therapist. Okay, I think he's here. He is here. Gosh, Instagram is so weird sometimes. I don't get it. So,
hello.
How are you, doctor?
Very fine, very fine. Nice to meet you. Nice to meet you.
Same here. So do you want to quickly give a introduction for yourself instead of making it very formal? How about you tell the followers what kind
Sure,
of
sure, sure. So I'm Dr. Sabharwal. I am actually the founder and director of the Happy Tree. We actually run a de-addiction and mental health hospital. But because I'm a psychiatrist, I also deal with psychosexual issues, and vaginismus is overtly a psychosexual issue. So that's a very common condition that we actually deal with at our hospital. My main focus has always been addiction and substance use. However, I deal with a whole spectrum of mental health as well as psychosexual disorders. So that's about me. I've been doing the media circuits for about 4 years now. So I'm assuming a lot of your viewers would have seen me somewhere, either on the internet or on a channel somewhere. If they've not, well, good time to introduce myself. I hope that I will be seeing you again and again, and we'll be talking more. And again, lovely to be a part of this live, and lovely to enlighten minds and also educate people about this very common condition.
So glad we're having a talk about this, because I get so many questions around vaginismus and I have no other recommendation other than you need to speak to a therapist and maybe use dilators while talking to a therapist or somebody who specializes in psychosexual issues. So, Doctor, why don't you give us an idea of what vaginismus is in the first place?
Okay, so essentially, vaginismus is a medical condition which involves a muscular spasm in the pelvic floor muscles. Now, out of these pelvic floor muscles, the most common, and this is, I'm assuming you're the specialist here, so you'll be able to elaborate, but the most commonly affected group of muscles is the pubococcygeus muscle. Now, these are the muscles which are also, responsible for urination, bowel movements, intercourse, orgasm, childbirth, etc. And so it's not that, these muscles are always to be relaxed. In a lot of cases, they're required naturally to be contracted. But vaginismus happens when these muscles contract the moment there's either penetration or they're about to undergo a gynecological examination, or if they're trying to insert a tampon. So that's when this kind of this wall essentially the vagina basically walls up. That's the condition that we refer to as vaginismus. Now, vaginismus. I'm sorry, you were saying something?
I was just saying that's a perfect explanation. Thank you.
Okay. So if there's something that you'd like to add to the whole the mix, I'd love to.
Yeah, so like I tend to normally keep it very, very simple to understand, which is that because I have a lot of younger viewers, that's why
Right.
I want to sort of give a brief idea of what happens here as well, which is basically exactly what doctor said. Your pelvis has like a basket, where you have muscles that support everything that's on the inside. Sometimes this basket tends to clam up, and that's what happens in vaginismus. Certain muscles just go like, yeah, no entry. This is not going to happen. And it becomes very difficult to insert things, like you said, with gynecological examinations, with sex, with tampons, menstrual cups, whatever. Any kind of insertion can become very not just scary, but also physically painful, and even sometimes just not possible. So what would your general recommendation be for people who are suspecting they have vaginismus?
Well, the first thing would be to get to a specialist and actually have a clinical diagnosis in place. Because without a lot of self-diagnosis, in the Google era happens, and it's not again very appropriate. So for a clinical diagnosis, all of these symptoms, they have to be present at least 50% of the time while any object is being placed in your vagina. So that's a bare minimum. If it's less than 50%, we don't clinically consider it to be vaginismus. However, there may be exceptions where it's exceptionally hard for someone, in certain cases where the number is less than 50%. But for the general rule, it's 50%. Now, if you're looking at how frequently or how commonly we come across vaginismus, we're looking at anywhere between 5 to 20%, but the number's much higher in conservative countries, and that's why the range is very wide. So 5% at at the one end, and 17 to 20% at the other end. The reason for that is probably most likely sociocultural, because where these conservative cultures where women's rights, freedoms are often curtailed, and then they're not really allowed to express their sexuality freely. That's one of the main reasons for why this number varies so widely. So in highly westernized societies and highly egalitarian societies, this number is tends towards the lower side of the spectrum. Now, vaginismus again. If you're asking me about what patients should know about vaginismus, well, also there's types of vaginismus, and I don't know if you would like me to elaborate on that, but I mean, whatever you say.
I think that could become a little bit more technical for our fairly young audience.
Right.
So let's talk a little bit about why you're mentioning since you're mentioning that there is a socio-cultural thing. That's why we tend to have it more in this part of the world, or more conservative countries. So we need a lot more sex education. So there's people like us that are coming in and doing the work. So I was trying to also get an idea of how, other than the fact that there's social cultural reasons, what other reasons can lead to vaginismus? Can somebody be born with vaginismus, or this is something you get over a certain amount of time, or this is something you can just suddenly one day wake up and have vaginismus? How does this work?
So, vaginismus, when it's primary, that essentially means that it's been there since forever, since you could recall, and that the first time you actually experience it is when you're either trying to insert a tampon, or you're trying to penetrate either with your finger or with your partner. So that's called as primary vaginismus. That's basically essentially that you're born with. Secondary essentially means that you've been functioning normally before, but then something has happened, and that something has led to vaginismus to develop, and then you're experiencing a lot of difficulty after having been able to function sexually normally for a long period of time. So that is really the difference between what we refer to as a primary or a secondary vaginismus. Now, other factors that you mentioned that could lead to vaginismus could be, if you're apart from the social-cultural aspect, where there's a lot of shame, guilt, etc. You've been in our cultures and Eastern cultures, sex is considered to be a taboo, and most people have a very strict upbringing, where sex is not discussed. Sexual desire is to express it is seen as as promiscuity. So women often repress their sexual desires, and also yes, and overtly, a lot of religions also look at sex the wrong way. So I'm not going to name any specific religions, but most of our religions actually look at sex as being just a means to procreate, and so people who are overtly religious also unfortunately tend to suffer from the consequences of that sort of mindset. But if you're looking at a non-sociocultural aspect, let's say, how would that be, and why would that be in a westernized or in an egalitarian kind of situation where let's say men and women are equal? That could essentially basically involve either if you're really scared of getting pregnant, you're young, you're 13, 14, and this is the first time you're having sex, and you're really scared of getting pregnant. You could have a lot of anxiety. You've not had sex before. Or you've had sex, but now this is a new partner, and you've been reprimanded by your partner before about not being good enough, quote unquote, in bed. Maybe you have guilt. Maybe you're cheating on your partner. And cheating again is in quotes, because that's again a relative term, and that's subject to people's morality, etc. Now, so some people have relationship problems. For instance, if your partner, is. And when I talk about vaginismus, I don't just mean a male penis. It can also be a strap-on with a female or a trans. So again, let's not be restricted to
let's
one
not restrict
gender and
ourselves to
sex.
gender. Yeah.
Yeah. So in a relationship problem scenario, you could have an abusive partner or a partner who's involved in substance use, etc., with other partners, and you've been emotionally or physically abused, and you feel vulnerable, and you don't want to let go of that control of your body in front of that person. You could have a lot of traumatic life events where you've seen either someone being raped, or you've been raped yourself. You've seen your parents or your mother being sexually violated at some point. You've seen your sister being sexually violated at some point. You've also probably been, in childhood experiences, you could have had a very early exposure to sexual images that could have shocked you, and that shock factor has kind of basically essentially triggered what is referred to as a fear avoidance cycle. Now, again, you are the person who'll be able to kind of explain it in very basic, simple terms, because I find it very difficult to kind of dumb it down that much. But that fear avoidance cycle essentially means that you get scared of the sexual act, and then you begin to avoid the sex, and that makes the fear even more. So when you try to have sex later, that makes it worse. And then this cycle is kind of a self-propagating kind of cycle. And then, the only way out of this cycle is to kind of get help.
Yeah. I've also seen vaginismus in a couple of patients of mine who have, just vaginitis, which is inflammation of the vagina. So sometimes if you have an infection, your vagina can be inflamed, which can make sex so painful that your body just rejects the idea of sex. Aside from this, another condition that actually very unfortunately I've seen quite often, at least in this part of the country, is something called, so this is for the audience, so there's something called an episiotomy, which is basically when you're trying to deliver vaginally, sometimes the hole is not big enough, so they have to make a cut. And sometimes when stitching up this cut, there can be scars that can form there, or the stitch can be too tight, which can make it very difficult to actually have sex, or the scar can be painful. And because of these, people who were not born with an issue, or don't have a psychological issue with being afraid of sex, they physically cannot have sex because it's just too painful in these conditions. So if you have an infection, if you have any inflammation, if you have scar tissue around there, these things can also contribute, aside from the psychosexual angle. So so there's this TV show called Sex Education.
Menopause again. And when we look at menopausal women suffer from a lot of it because of the lack of the hormonal stuff happens, and then there's a lack of lubrication and elasticity, and that makes sex really painful. So that's another, I think, very pertinent organic cause for this.
Absolutely, that's a very important sort of aspect that we do need to address, because when we talk about sex, we never think about older people. We only think sex is something that young people have. So menopausal people can find it very difficult. So there's this TV show called Sex Education. I don't know if you've seen it, and they have this character in it who is who has found out she has vaginismus, and she has dilators in her room. So she uses these dilators every so often to make it easier for herself to have something inside there. So could you tell us a little bit about how dilator therapy works? Who does somebody approach for this? Do you go to a physiotherapist? Do you go to a psychiatrist? Who is supposed to guide you along this? And is dilator therapy enough, or do you need something else along with it?
So when we look at management of vaginismus, this is the simplest version of how we manage it. But simply buying a set of dilators is not going to help you along the way. I'm not sure if you're talking about the shows. I'm not sure if you watched the show Masters and Johnson, because they have a book, and it's a very thick book. Masters and Johnson actually pioneered the technique of, it's a behavior therapy technique called the sensate focus technique. So it's a form of sex therapy that is really the hallmark, I mean, is the gold standard when you look at treatment for vaginismus. This technique actually works on a behavior therapy module called gradual desensitization. So let me give you an analogy of how this works. Let's say you're extremely scared of spiders. You come to a therapist, right? A psychologist will come and talk to you about your fears, etc. How do we get you to stop worrying about the spiders? The first thing is we're going to talk about we're going to encourage you to think about it in your mind, so that the images come to your mind and that evokes an emotional response. Now, when you think about it and the emotional response comes and you realize that the consequence is non-threatening, which essentially means that nothing happens, that is when your reaction to that specific event, thought, image, whatever you want to call it, lessens in intensity. The next step is we're going to show you some pictures of spiders. And every time you see a picture of a spider, we're going to tell you to feel the same way as you tried to feel earlier. As we would expect, your reaction to it would be less emotional. Then gradually, then we're going to place in front of you a dummy spider, right? And then we're going to tell you to react to the dummy spider. And then the next step would be to place an actual spider in a box and put it in front of you, right? And then the last step would be to have a spider which is obviously non-venomous and put that on your palm or on your somewhere on your body. This is gradually as we increase the exposure, your emotional response to it decreases in intensity to a point where it becomes extinct. So extinction of a response essentially means you're not emotionally triggered the way you were the first time. Right. Now, this is the behavior therapy module that sensate focus essentially works on. Now, this can be tried at home, either alone or if you have a partner, of course. Now, let's say that you want to know your body a little bit, you have some time, you explore your body, see what feels good, try to touch yourself in your genital area. But before you try to actually penetrate yourself, you have to begin to initiate this sensate focused experience where you're trying to enjoy the experience of being touched. It's essentially feel what you feel, when either a penetrative experience is happening or a non-penetrative sexual experience is happening. And gradually, when you start focusing on the journey rather than the destination, that is when you're going to be able to come out of this. Now, this is when the dilators come in place. So the dilators are not what we start off with. The dilators come once the other stuff doesn't work. So if I was to, let's say, if you have a sexual partner, both of you agree that you will not have sex for a number of weeks or months. During this time, you can still touch each other, but not in the genital area or in terms of, for a woman, in the breasts. Set aside, for a time when it's just the both of you. You can massage yourself, touch, stroke each other, with or without clothes on. Explore your bodies, knowing that you will not have sex. Now, after there's an agreed period of time where you've decided that after a month we're going to engage, that is when you begin to kind of start touching each other's genital areas. Then this might take another couple of weeks because you're simply touching it, fondling it either with your mouth or your hands, etc., but still not penetrating it. Once that barrier is breached, then you can start with the fingering, etc. And then once that barrier is breached, then the last, of course, barrier is to start penetrating. Now, once all of this fails, that is when the dilators come into the picture. Right? Now, again, there's there's an ethical issue around pelvic floor physiotherapy, but essentially what that means is there's a probe that goes inside the vagina, and then it's connected to a biofeedback machine. And then what happens is the person is able to see that they're contracting the moment that the probe is inside their vagina, and then through biofeedback they're able to relax it. But then there's a major ethical issue around it, so we don't practice it at all in India.
Okay. Oh, that's interesting. Huh.
Yeah.
So that was very well summed up. Like, I think that was a very wonderful explanation on how this works. And actually, even I learned a lot because I had this entire time, every time somebody asked me about vaginismus, my only suggestion is speak to a therapist who can guide you and use dilators. Right. But this is wonderful, you can sort of, I feel like this is a very important message that has to go out, that people with vaginismus feel like they have nowhere to go to. especially people like in smaller cities. For example, I'm based in Allahabad, and I do have 2 patients over here with vaginismus. And they feel very concerned that there's no psychosexual therapist over here, or who do I approach for this? Then regular gynecologists don't take me seriously on this. So I feel like this can be a very good way for people who are concerned about vaginismus to find resources and to find the right person to speak to. It doesn't necessarily have to involve therapy. It doesn't necessarily have to involve dilators. The couple can do this on their own. The person can do this on their own. Sex doesn't need to be penetration. There is such an important message that has to go out with this.
But then sometimes what happens is, yes, sometimes what happens is even with sensate focus, we don't see a response. Now that could be because of either because of an underlying condition or a medical illness. Now let's say we've solved all of the underlying psychiatric problems, relationship problems, everything we've solved out, right? There was one point that you mentioned in the beginning, and that's I think probably our last option when we look at vaginismus cases is what do we do to help with medications or surgery for a person who's had vaginismus issues. So the next step after therapy is of course medication. Now what we essentially do with medication is that we'll prescribe the person a benzodiazepine, or basically a anti-anxiety medication that to take just before sexual activity so that the person is able to relax. Let's say that doesn't work either. Then what you mentioned about episiotomy, I think that's again something that you'll be able to shed light on. The Fenton's procedure is one procedure that, of course, we don't do as psychiatrists, but again, you'll be able to touch upon that much better for someone who's had an episiotomy following childbirth, and then there's the vagina. Of course, essentially, it shrinks in size, and then the scar tissues needs to be kind of removed. That's the last one. I'm not sure about botulinum toxin though, because again, that's not my specialty, so I'm not sure what the evidence for botulinum toxin is. But as far as my knowledge goes, that is also a procedure that is right now, in the process of being researched. Again, it's not my specialty, so I won't be able to touch on that much.
I actually have a question regarding that. So if you give Botox to somebody in their pelvic floor, what about the pelvic support? Like, for vaginismus, sure it works, but what about the support? Doesn't that increase your chances of getting a prolapse, which is for the audience?
Yes,
basically,
yes. So that's
it becomes loose.
I mean, I'm thinking about urinary incontinence and all of that other stuff.
Yeah, exactly.
So
incontinence, prolapse,
so
everything.
I'm not really sure what the evidence is for botulinum toxin, but I read somewhere that Botox is also now being considered for it. Now, since I don't have zero experience on it, so I can't really comment on that. That's for a surgeon to kind of at least to comment better on.
But there's also the issue that we don't have pelvic physiotherapist as such in India. We don't have a speciality as like a pelvic physiotherapist or post childbirth physiotherapist, somebody who can help with these things. So we do have a long way to go with this.
Major ethical concerns with this stuff.
Also that. So is there sort of a concluding remark you would like to leave for the viewers who have questions? And once we've taken that up, we can see if we have audience questions that we can take up, because I'm seeing a few questions over here.
So the concluding remarks are essentially, if you have vaginismus, don't assume that you have no options out of this, because there is certainly a way out. And also, while you're figuring a way out, remember that you can still get orgasms, you can still enjoy sexual activity other than the penetrative bit. So don't give up on that part. Maybe your sexual pleasure, orgasms, etc., will any which way help you overcome vaginismus. So don't lose hope. If the issues are psychogenic, it's 100% curable, 100% reversible. So do not lose hope if you have that.
That is a wonderful summation. I'm so happy to hear that. So let me just go through the comments and see if we have any questions that we can address with this. And for everybody who's commenting and saying, please save this live. Yes, this live will be saved on my IGTV, so you can find it there. Let's see. Okay, we've had some random questions. And is psychotherapy used to cure vaginismus? So we've already addressed this over here. Can someone have vaginismus even if their hymen is broken? or like it seems like
Yes,
the vagina has opened up. So I think they're
yes.
asking about secondary vaginismus here.
It has nothing to do with the hymen. Hymen has absolutely hymen is just a body part, right? Vaginismus is a condition which is a reaction to essentially pain. So it's completely different. They're not. The two are not the same.
There's another question that says, what are the symptoms of vaginismus? So could you tell us, I mean, not that we haven't covered it, but are there any symptoms we've missed possibly?
Yes. So extreme pain. Now this pain has to be at least 50% of the times either when you're trying to insert an object, trying to have intercourse, trying to undergo a gynecological exam, trying to insert a tampon, etc. This can also be associated with a breathlessness, spasm of the muscles, and this can also essentially be triggered by simply touching the person in the vaginal area. These are things that are essential for vaginismus to be diagnosed. Other than if they don't happen, we don't diagnose vaginismus as is.
Wonderful. I see a really interesting question here, which is that can vaginismus come in different stages? That is to say that some insertion works, but some doesn't.
Yes, that's so. Symptoms of vaginismus vary in severity with different women. For example, some women can have, they're unable to insert anything into the vagina. Some women can insert a tampon and undergo a complete gynae exam, but they're not able to have intercourse. Some women can try to have intercourse, but then it's very, very painful, right? Some women are able to have intercourse, but then because of the pain associated with it, they're not able to orgasm, but they're somehow tolerating intercourse. And then some women have a very mild version where they're tolerating the mild occasional pain for years on end, but then these symptoms, they flare up and then they go down, then they flare up, then they go down. So based on their experience, life experiences, etc. And so they have to constantly try to keep relaxing and exercising their muscles. So it's a big spectrum. It's not a black and white kind of a scenario here.
Absolutely. I think the spectrum is the right way to sort of define this. If you're able to insert a finger but penetration is not possible, is this vaginismus? So like you just said, yes, it's a spectrum. This could be vaginismus. If anyone wants to pursue psychosexual therapy in India, where can they learn it?
If anyone wants to,
Slightly off the tangent. If somebody wants to pursue psychosexual therapy as a profession in India, where can they learn it?
come to us, come to the apple tree. We'll be happy to guide you. we
Wonderful.
we offer free observerships, free internships to all psychology students. So please feel free to come.
Fabulous. So there's another question that I think is quite interesting, which is how do people without partners navigate treating vaginismus without, say, without accessing therapy? So like you mentioned, with the touch and the, not making penetration the part of the sexual act, how would somebody who doesn't have a partner do this?
Well, you have to replace the penis or the strap-on with another probe, right? So the set of dilators is the most easy way to explain this is that's the last in the process. But again, you have to first explore your body, start feeling relaxed, start trying to look. The first thing is to look at your vagina in the mirror. Just place a mirror in front of your vagina and look at it. Don't be ashamed of your vagina, right? Have a look down there and see what it is. And it's beautiful, right? Everyone's body is beautiful. We should not be ashamed of our body. Now get used to what it feels like when you touch the labia majora, the outer lips and the inner lips of the vagina. And then essentially once you're trying to get comfortable, try inserting your finger. If it doesn't insert, don't worry. It may take a day, a few days, a few weeks. It doesn't matter. As long as the progress is being made, it doesn't matter the pace that you're going. Now, one thing that I forgot to mention was that if you're having a lot of difficulty and you don't have a partner, you could use a lube, and a water-based lube is essentially the best way to go about it. Now you could essentially have a lubricated either a tampon or any kind of probe, and that also eases the pain a lot. If you still have pain, you could self-medicate with over-the-counter pain medications as well. Now as a doctor, it's very it's very tricky for me to kind of say self-medicate, but over-the-counter pain medications, you might want to try them out.
Wonderful. I have another question that I don't know. I'm not sure if we both have the ideas to answer this. So there's this another medical student. He's a very smart, upcoming medical student. His name is Porus, and he's asking, What can be done in the public health field regarding vaginismus? I mean, I don't have an answer to this other than education.
What
We
can
just
be done?
need to
What?
educate
I'm sorry.
people
What can be done? What did you say? What can be done?
in the public health field regarding vaginismus.
Well, the best we can do is
So
disseminate education, right? Sex ed is uh, is one of the main things that we can do at a public health level to completely extinguish. I mean, this is a completely 100% reversible, curable, avoidable, preventable kind of thing. It's something like smoking, right? It's a completely preventable condition. So we should definitely look at spreading the
that
word around about. This is why I love the work that you're doing, because you're breaking these walls of taboo, every day, and it's lovely to see someone
thank
who's
you.
doing that. We need this. We need to break
Thank you.
these taboos.
Absolutely, it shouldn't be a taboo in the first place. There's another comment that I do want to address here. There's somebody saying, as someone with endometriosis, I finally feel informed, and that is really important, because sometimes people with endometriosis can also have vaginismus. If you have pockets of your endometriosis tissue inside your vagina, in between your vagina and your butt. So these are areas that can make it very sensitive when having sex. So, for this, possibly the only treatment is getting surgery for the endometriosis, and this can get quite complicated. So I'm not going to get into this. But yes, endometriosis is another thing that sort of I forgot to mention over here. Okay, I feel like we've got, as someone with endometriosis and who isn't sexually active, how would I know if penetrative sex would hurt? I'm going to take up this question because I really enjoy talking about this, which is that a lot of people are very afraid of sex, and that is another thing, like you mentioned, that can contribute to vaginismus. And the reason why people are so afraid of sex is because, we have this idea that the first time is meant to hurt. But that's actually not true. If you use enough lubrication, if you use enough foreplay, the vagina actually becomes relaxed. It doesn't stay, as closed off as it normally does. And with that relaxation, it becomes automatically easier to insert anything, whatever kind of penetration you're going to go for. So I really, really hope that first, this myth around the fact that your first time popping your cherry is going to hurt thing goes away. And secondly, if somebody has endometriosis and and they have this question, unfortunately, this is very difficult to answer without actually experiencing sex for the first time, because we don't know where your endometriosis tissue pockets are, essentially. So there's
So
another question.
I also had a request, if you could clear people's doubt on water-based versus oil-based lubricants, and when are they preferred in terms of sexual activity? I mean, I am also quite curious about it, because everywhere I read it says always prefer water-based lubricants, but then why do oil-based lubricants exist?
So if somebody is not going to use condoms, that's a great time to use oil-based lubricants. Also, oil-based lubricants can be more comfortable for somebody for things like anal sex. If you're not going to use a condom there, water-based lubricants you need to use a lot, essentially, to provide that same slippage that an oil-based lubricant can provide with a little bit of amount. Also, some people
Okay.
just prefer it because, I think that's a personal choice thing. Um,
Okay.
I don't think I've ever recommended an oil-based lubricant to anybody. If somebody wants more slippage, I recommend silicone-based lubricants. But yeah, I think it's a choice thing more than anything else. So there's just a couple of comments I want to quickly take up, which is, okay, if everybody's just saying please save this life, so guys, don't worry, we'll save the life. We'll definitely save the life.
Looks like a pretty popular topic.
Is there any? Absolutely, it's a very popular topic, and unfortunately, there's not enough information. I mean, I work in this sector, and even I didn't know. I learned so much from this live today because there were so many things I had no idea about. So that's wonderful that we can talk about these things and create more conversations around this.
It says, so someone's asked a question, and they've said, what difficulties have you faced while dealing with vaginismus? You
Oh,
can
like
take that.
talking about
Do you want to take that question? While
when
dealing,
talking
I mean, in
about
terms of
vaginismus,
while dealing with patients of vaginismus.
Oh, okay. So I personally don't treat people with vaginismus unless they have a surgical issue that we can help correct. or something of that sort, because
Okay.
I feel like CBT as in therapy has to be an integral part of, for the audience. Therapy has to be an integral part of vaginismus treatment is what I thought up until now. That's why I never took up cases of it. I would refer them to people. Having said that, I feel like the first biggest problem that I tend to see with people who have vaginismus is that there's so much shame around it. They have so much shame
Right.
around their own bodies, because of, you know, like you said, because of social cultural reasons. We've had a very I don't know, taboo approach to sexuality and our bodies in general, particularly our, you know, our groin area and things like that. So I feel like this is the most difficult thing I tend to see, is helping them dismantle this I don't know, idea of shame around their own bodies. And like you said, you know, just sitting with a mirror. Actually, I'm doing an event with a couple of girls from Goa today, where we're going to just do this. We're going to look at our vulva and we're going to draw it, how we think our vulva
Right.
looks. And
Lovely. That's great. That's great.
we
Lovely.
yeah, I'm really excited about it. Being in the sort of field I am and talking about sex as much as I do on the internet, this is not something I've ever done. I've taken a look at my bits, yes, but I've never drawn them and talked about them in a public space. So this is going to be very interesting. And I feel like,
That's
you know,
the thing is, when you know, physicians, I mean, so I'm talking to you as a doctor, you're talking to me, there's no shock involved. But when this goes out in the public, it has some shock value, right? Because essentially we are two professionals talking to each other as professionals. So, but when you say,
yeah.
you know, present this to the public, the shock value that needs to be there is there. So I love the things that you're doing. There's so many good comments that I'm reading about. You know, that are, someone says, I wish I had half the confidence of you, Dr. Cuterus. So it's lovely that you're doing this,
Thank
because
you.
now when I engage with my audience, I'm essentially talking about the technical stuff and all of that, you know, other stuff, but you're making it fun. So that's why I love your approach to the whole Instagram stuff.
Thank you. You're very kind. Thank you. I feel like we've taken up most of the questions on that note. And
Yeah.
since you're talking about the fact that, you know, because we're talking as professionals, this is slightly different. But I see that even in our medical community, I tend to face a lot of, you know, raised eyebrows, and a lot of surgeons come and tell me, itne to hum bhi nahi batate hain apne patients ko. So, you know, there's also that stuff.
It's a lot of
You know, the
shit. So
shock
I
value is very much
honestly,
there.
like I no offense to people from my profession, but if you're going to let medical science be overtaken by your your sense of morality and all of that nonsense, I'm sorry, we're not going to be friends. You know, I mean, so like I said,
Absolutely. I
even
would
when we
agree
talk
on
about
that.
quote unquote cheating, I mean, I don't, as a psychiatrist, I don't judge people who quote unquote have cheated or who have monogamous or non-monogamous associations, relationships. We don't do that because it's not in our it's not our place to do it. You know, your personal values and your sense of social morality
Absolutely.
can take a hike.
Absolutely. That's a very sort of important point. Take a hike. So I'm seeing that there's a very interesting question that I don't know if we'll have the answer to. So somebody's asking, does meditation help with vaginismus?
Sorry.
Does meditation help with vaginismus?
I've not seen any articles or any evidence based for medication with vaginismus. I've not read up any research articles on that. So I'm sorry, I won't be able to illuminate you there.
I think that's also great that, you know, you're talking about the fact that there's no evidence for it, you know, because a lot of practice in our country doesn't come from an evidence-based view. So
Yeah,
it's
it's
great
quackery. A
that, you
lot of
know,
it is
we
quackery.
actually, yeah, a lot of it is quackery, even with like legit registered medics. You know, there's an orthopedician that I know. My mother had a pain in her, I think she was having pain in her arm or something, and he said, yeah, if you do what is it called, सुबह सूरज को जल चढ़ाइए और आपका सही हो जाएगा. He's an orthopedician. So, you know, this is the kind of stuff we tend to see. So I'm great we're talking about evidence-based medicine. I'm great we're dismantling
Yeah.
these questions around vaginismus and sexuality. And it's been a wonderful conversation with you here, Doctor. I'm so glad we could address all of these
Lovely
questions
to
and talk
be
about this.
talking to you.
Absolutely.
Please follow
So,
me.
guys, you have any
Please
more
follow my
questions,
updates. I'm pretty active on social media, so please follow my updates. And I'm also, in fact, the next video I'm doing is on vaginismus, so it should be coming out in a day or two.
Hey, wonderful.
I'm going to be talking about the definition, the causes, the treatments, and everything. So stay tuned for that. And for the audience, thank you for joining, and thank you, Dr. Kipris. She's also called Dr. Tanya. So Dr. Tanya,
Tanaya.
right? Dr. Tanaya, okay. Dr. Tanaya, lovely to be talking to you. And please follow the both of us. Thank you for joining us. And
It was a pleasure.
have a great Republic Day.
Thank you so much for being here.
Bye-bye.
Bye.